All right, I'm talking about hemolytic anemia and broken up into two subclasses, intravascular and extravascular. So on this side of the board, I have extravascular causes, and on this side, I have intravascular. And then on each side, I have 4 over here and 5 over here. And I'm just kind of touching on them briefly to catch the high yield things to take home on these. So for extravascular hemolysis, the hemolysis is happening like in the spleen, liver, other places other than the blood cells themselves in the vessels. So the first one I'm going to talk about is hereditary spherocytosis. So as the name says, it's hereditary, autosomal dominant, and then spherocytosis. So obviously the cells are round and they're not as flexible. So when they go through capillaries in the spleen and stuff, it notices that they're not as bendable. So that causes them to hemolyze. So it's caused by membrane protein deficiencies that are supposed to make the red blood cells have that biconcave shape. And since they don't, they kind of ball out into a sphere and they bleb off these little pieces, these little circles. So this whole memory mnemonic or device about spherocytosis is about spheres, because the cells are spheres. And then spherocytosis, the SC for Santa Claus. Remember this was Santa Claus, SC, spherocytosis. Also because it affects mostly like Northern European people, so I think like up near the North Pole. So Santa Claus in the North Pole, and he's a very round, jolly guy. So he's round, just like a spherocytosis, a spherocyte. And he has decreased deformability, can't make it through the small capillaries. So he's trying to go down the chimney, but he's stuck here on the top because he can't deform down into the chimney or the capillary. And then the other thing with these spherocytes have decreased or they're increased osmotic fragility, because if you have a biconcave red blood cell and you put them in a hypotonic solution, they can swell. Water goes into the cell and they can get bigger. But for a spherocyte, they're already swollen. So if you put them in a hypotonic solution, they can't really swell as much, so they're going to burst. So they have a lot greater osmotic fragility. So that's why Santa Claus here is eating a cookie, and he's dipping his cookie, which is also round like a spherocyte. He's dipping it into the milk like Santa always likes to do. And it's fragile, so you put it in the solution and it crumbles, it falls apart, it gets soggy. It's fragile in the hypotonic solution. It also has an aplastic crisis with parvovirus B19. And so like you're not producing as much blood cells, and aplastic crisis. So you see that Santa Claus has dropped his bag here with all of the toys in it, so plastic toys, and since he's stuck in the chimney, it's a crisis. All the kids can't get their plastic toys, so aplastic crisis with parvovirus B19. And you have an increased MCHC because the shape of the cell, they're larger, so they'd have more hemoglobin concentration. So moving on now to HBC disease. This is autosomal recessive, and it's a point mutation that changes glutamic acid to lysine. So something you would see on a peripheral blood smear for this is podocytes or target cells. So here I have 2 target cell looking cells or podocytes, and there's a point in the middle because it's a point mutation. And you can't really see it, but they're actually 2 C's I have making up the outside of the target, a forward C and a backward C to make up the target cell, because it's HBC, and they have HBC crystals. So the eyebrows here on his eyes are the HBC crystals, and it made it look like 2 eyes because the glutamic acid is changed to lysine, and so like you've seen it, so I think of eyes. And that's all I have for that. So now let's go on to sickle cell anemia. This is the disease. So you have homozygous mutation. It's autosomal recessive. The classic findings with this, someone would have chipmunk faces. So I have a chipmunk here, and they would have a crew cut appearance if you take an x-ray like of their skull. And so he has kind of a crew cut haircut here. and hepatomegaly. So he has like a big side of his belly there where the liver is. He's holding a sickle cell here to remind you that it's associated with sickle cell disease. And in the other hand, he has a trophy that has a glue bottle as the trophy because it's glutamic acid to valine. So like he's valorous, he's got a trophy. So glutamic acid to valine is the mutation causing this. And he's also got very big hands and feet because dactylitis is the common finding in children at about the age of 6 months. That's their first developmental sign of it because before that age they have hemoglobin F, and that's when it starts transitioning to the adult form of hemoglobin. And the first sign you would see is large hands and large feet, or dactylitis. So the definitive diagnosis for this would be a hemoglobin electrophoresis, and so they would be kind of sorted out, and you would see that they were abnormal hemoglobin. For adults, the things that can cause mortality, the symptoms of this, you could have a stroke, you can have acute chest syndrome, you can have bone marrow necrosis, osteomyelitis, and basically all of these are caused by vaso-occlusive crisis. So if you have the sickle cell shaped red blood cells and they're getting caught in the smaller vessels, that's going to lead to the stroke and the acute chest syndrome and like the bone pain. You'll hear a lot of people complain about pain in their bones, and then the necrosis. So about osteomyelitis, osteomyelitis in a normal sense of a person, you would think it's caused by Staph aureus, but in a sickle cell patient, it's caused by salmonella. And so that's why I have this chipmunk here with his little salmon friend by his foot that he's standing on because he's valorous over it. But just remember that salmonella is the main cause of osteomyelitis if you have a sickle cell patient. Some sickle cells can be normal red blood cells, but when they're under certain conditions, they turn to the sickle shape. That's when you have hypoxemia, dehydration, or acidic environment for them. And if you re-oxygenate them and put them in the right environment, they can turn back into a normal red blood cell. But they can only do that so much because over time that becomes damaged. So that's when they would become hemolyzed, when they're damaged like that. So if you identify someone with sickle cell disease, you want to make sure to get them vaccinated, especially with like the pneumococcal vaccinations with all the variants, because people with this disease are a lot more susceptible to encapsulated bacteria. That's because it can cause asplenia or autosplenectomy, and because the cells kind of destroy the spleen when they go through it, they cause fibrosis and destroy it. So you're a lot more susceptible to those encapsulated bacteria. Next, I'll talk about AIHA or AHA, and you have this in extravascular and intravascular over here, and they're a little bit different. So they're autoimmune, and if it's extravascular, we call it a warm AHA, and it's IgA mediated. And then if it's on intravascular, it's called cold, and it's IgM mediated. So I'll go through these two to kind of differentiate between the two. So if this one is IgG mediated, I drew some IgG looking molecules here, and these are extravascular. So I have them on the outside of a cell here, just to remind me that they're extravascular or outside. And they're warm, so this also kind of looks like a sun to me. So I remember that extravascular is the warm with the IgG. It's associated with diseases like SLE, RA, and CLL. It can also be caused by taking certain drugs like penicillin, quinidine, and methyl-dopa. And it causes harm by opsonizing the cells, and then they're phagocytized. So another thing about this picture that helps me remember that it's hemolysis by opsonization is I have the IgG on the outside, like here, like they're coating the cell. So that picture is really simple, but it has a lot to it. And then also you see spherocytosis with this, just like the hereditary spherocytosis. And so again, this is a circle for spherocytosis. And then moving on to the intravascular hemolysis with AHA, and this is the cold one. I'm going to share here. So I already said it's IgM mediated, and so I have some IgM looking molecules here, and they also remind me of snowflakes, so that helps remind me of that it's cold and intravascular. You see I have them inside the circle over here, so that's another thing that makes me remember that they're intravascular. They cause crazy agglutination, so that's why they're kind of all stuck together here, because IgM is also very sticky, so you think of it with agglutination. And so it's also intravascular, I think of, because IgM is like very large, so you wouldn't see it like going outside of the vasculature, and that's just another thing that helps me remind me that it's intravascular. Again, spherocytosis, so you have these circular cell-looking things outside of the IgM. And it's associated with mononucleosis and Mycoplasma pneumoniae. So think of all the M's. So it's IgM, mononucleosis, and Mycoplasma pneumoniae. And the way that it causes hemolysis is complement fixation. One of the symptoms you would see with this is dark urine. Okay, so now these are the other intravascular hemolysis mechanisms over here, and I think I'll go with MAHA next. It's a microangiopathic hemolytic anemia. This has schistocytes, and that is something you would expect with microangiopathic, because if they're going through the small capillaries, the small vessels, when they're getting destroyed, they would get schistocytes. Schistocytes look like shit, like they're poor-looking cells. And a couple of the different diseases that you would see this with are TTP and HUS. So with TTP, you would have a decrease in ADAMTS13. ADAMTS13 is something that when you have von Willebrand factor come out to cause clots, it's in a very large form, and the ADAMTS13 breaks up that von Willebrand factor and makes it smaller. So if you have a decrease in ADAMTS13, your von Willebrand factor is going to be very large. So you have these large clots causing hemolysis. And then with HUS, that's caused by E. coli 0157H7. So it's hemolytic, and it involves your kidneys. And you see it a lot with children having like undercooked hamburger meat. And some of the symptoms that you would see with TTP or HUS, which are kind of grouped together, you'd have fever, anemia, thrombocytopenia, renal insufficiency, and neurological abnormalities. And the mnemonic for that is FAT-RN. FAT-RN are the symptoms you see with TTP, HUS. So there's a lot of mnemonics here, but the symptoms would be fever, anemia, thrombocytopenia, renal insufficiency, and neurological abnormalities. The treatment for that would be plasmapheresis and steroids. And you would think, since they have thrombocytopenia, that you would want to give them more platelets, but you'd never want to transfuse these patients with platelets, because it's kind of adding fuel to the fire, because if they're throwing clots, then you don't want to give them more platelets to add to that clotting issue. The other disease associated with this is DIC. This is another one where you're throwing inappropriate clots, and things that can cause DIC to occur are sepsis, burns and trauma, abruptio placentae, that's associated with cocaine use mostly, and acute promyelocytic anemia can all lead to DIC. And the best way to test for this would be if the patient has increased D-dimer. And if they have increased D-dimer, it might not necessarily mean they have DIC, but it has a very strong negative predictive value. So if they have a negative D-dimer, then you can pretty much rule out DIC. And these are just some under the category of microangiopathic hemolytic anemia underneath the intravascular hemolysis. So obviously, if it's microangiopathic, it's in the vessel, so it would be part of the intravascular. Next, I'll talk about PNH, or paroxysmal nocturnal hemolytic anemia. This is acquired. It's not something that's actually inherited. I have a picture of a little guy laying in bed here because it is something that happens at night. It's nocturnal. So he's also outside of his covers. He's not protected in his covers. So that helps me remember the cause of this. There's normally a GPI protein on the outside of cells that protects them, on red blood cells, that protects them from being destroyed by complement because they're recognized by the body. But in the PNH, they're actually lacking that GPI protein, which is a shield on the outside of the cell holding other proteins to protect it. So if you don't have that attachment protein, you can't have the other proteins that protect you. So you have kind of an exposed red blood cell to the complement system. And so that's why this guy is on the outside of his covers, because he's exposed. He doesn't have protection from the monsters. So the reason why it happens at night is because at night you have more shallow breathing and you'll have increased carbon dioxide, and it creates kind of an acidic environment. And that's kind of a happy environment for a complement to take place. So you have increased complement destruction of your red blood cells. So that'll cause a patient to have dark urine in the morning when they get up to pee. You'll have thrombophilia and aplastic anemia. And there's also an increased incidence of AML and MDS with these patients, obviously with the aplastic anemia. And if you are trying to diagnose the patient with PNH, you can run a sucrose test or a acidified serum test or a flow cytometry. And the thing with the sucrose test and the acidified serum test that help you realize if it's PNH is because both of those things cause one of those favored environments for complement to take place, like I was talking about when you're sleeping and you have the acidic blood. All right, so now we'll talk to you about G6PD deficiency anemia, and this is the most common enzymatic deficiency cause of anemia in the world. And I have a picture of a hamburger right here with a side dish of beans, and you can't have a hot dog or a hamburger without ketchup, so there's ketchup being poured onto it. And there's a big bite being taken out of the hamburger. Just think of the hamburger as the red blood cell. It's round, and there's a bite being taken out of it because these blood cells that have G6PD deficiency are going to have these bites out of them. They're called bite cells or degma cells. So I think of the round hamburger with a bite out of it. And that's done in the spleen when it senses these cells without the G6PD, yeah. It takes like a bite out of them. And it also will issue these things called Heinz bodies. So I have a Heinz ketchup bottle being poured onto it, and that's visualized with a super vital stain. And I have the Heinz bottle being kind of misshapen and pouring out red dots like this, just to show that with this disorder you would have like a red or dark urine. So I have like the red dark ketchup bottle being peed out from the penis looking bottle. And also, if you consume fava beans, which are very common in the Mediterranean, that can lead to increased hemolysis in this disorder, and a person can go into a hemolytic crisis. And apparently Hannibal Lecter also likes fava beans. So this hemolysis has byproducts that are toxic to the kidney. So people with this might present with like low back pain and abdominal pain because their kidney is being toxified. And more to do with that is because this G6PD is a part in the tract to reduce reactive oxygen species. So it actually maintains glutathione in the reduced state, which is, again, part of the line to reduce reactive oxygen species and protects it. So if you're deficient in it, then you're not going to be as protected against those reactive oxygen species. So that's why I have an H2O2 bottle up here being sprayed onto it just to kind of keep those together. Some drugs that can also cause this deficiency to rev up are primaquine, sulfa drugs, nitrofurantoin, which is a UTI drug, aspirin, and dapsone. And so those were the intravascular hemolysis causes. And some things that you would see just in general with intravascular hemolysis, you would see dark urine because it's intravascular and your kidney is filtering it out. So you'd have, that hemoglobin in your blood making it red. You'd have increased LDH in your serum and unconjugated bili. And then you'd have decreased haptoglobin. And all of that, again, is because of hemolysis and the released hemoglobin. With extravascular hemolysis, just in general, you would see jaundice, splenomegaly, and pigmented gallstones. So extravascular hemolysis, in the spleen. So it's overworking, so it would be causing splenomegaly. And then also in the liver, and you'd have extra bili from being destroyed, hemoglobin. So that causes jaundice, and you could have icterus in the eye and pigmented gallstones from the extra bili.